Accessing the upper and middle regions of the facial skeleton requires massive, unobstructed exposure. We need to visualize the entire zygomatic arch and superior orbital rim simultaneously to address complex fractures or perform extensive reconstructive work. The definitive solution for gaining this required level of access is the coronal or bitemporal incision. By extending the incision across the top of the head and bringing it down into the preauricular area, the surgical scar is kept completely hidden within the hairline. Mastering this massive exposure requires a rigorous first principles understanding of the distinct tissue layers forming the midline. Successful facial reconstruction hinges on identifying and separating these exact pre-existent fascial planes rather than blindly cutting through the soft tissue envelope. To decode the midline anatomy, we rely on the classic textbook mnemonic, Scalp. Looking at the top inset of this illustration, we can trace these precise layers above the superior temporal line: skin, subcutaneous tissue, aponeurosis, loose areolar tissue, and pericranium. The S and C layers represent the skin and the subcutaneous connective tissue. Unlike elsewhere in the body, the subcutaneous fat here contains a high density of hair follicles and is surgically inseparable from the overlying dermis. Beneath the fat is the A layer, the aponeurosis. Frequently referred to as the galea, this is a dense, glistening sheet of fibrous tissue, roughly 0.5 millimeter thick, spanning the gap between the frontalis and occipitalis muscles. Because the skin and fat are tightly bound to the superficial surface of the galea, with no natural plane of cleavage, all three of these structures move mechanically as a single functional unit. Treating these top three layers as a singular, indivisible structural flap is the first rule of coronal reflection. Immediately deep to the galea is the L layer, the subgaleal fascia, also known as the loose areolar layer. This specific layer provides the critical avascular cleavage plane. It allows the overlying skin, subcutaneous tissue, and galea to be stripped efficiently from the underlying bone. Mechanically, this plane yields so easily that it is the exact anatomical location where traumatic scalp avulsions naturally separate under extreme shear force. Anteriorly, this subgaleal fascia is continuous with the loose areolar layer deep to the orbicularis oculi muscles. Laterally, it attaches directly to the frontal process of the zygoma. Beneath it lies the final P layer, the pericranium. This is the periosteum of the skull itself, a fibrous membrane that remains firmly attached along the cranial sutures. Utilizing the subgaleal plane is the safest, fastest, and most biologically sound route for mobilizing the midline cranium. Moving away from the predictable anatomy of the midline, the surgical requirements shift as we enter the highly complex lateral temporal region. Notice layer A in this dissection. The thick midline galea transforms into the thinner temporoparietal fascia. Lying directly beneath subcutaneous fat, it's easily missed. Strict rules apply. Blood vessels run along its outer aspect, and motor nerves run exclusively on its deep surface. The temporoparietal fascia serves as the ultimate physical boundary layer, separating the superficial blood supply above from the critical deep motor innervation below. Moving one plane deeper, we trace the subgaleal fascia as it continues laterally from the midline. Looking at the right inset, beneath the subgaleal layer is the thick temporalis fascia. It descends and splits at the superior orbital rim. The superficial layer attaches to the zygomatic arch, the deep layer medially. Sandwiched between them is the superficial temporal fat pad. This splitting fascial architecture and the intervening fat pads create the necessary glide plane but allows the underlying muscles of mastication to function smoothly. Navigating this lateral architecture brings the surgeon face to face with the highest stakes structure of the approach, the temporal branch of the facial nerve, cranial nerve 7. This nerve supplies exact motor innervation to the frontalis, the corrugator, and the procerus muscles. Severing this branch has severe clinical consequences. The patient completely loses the ability to raise their eyebrow or wrinkle their forehead on the affected side. This medical illustration maps its highly variable trajectory. As the temporal branch crosses the zygomatic arch, it can lie anywhere from 8 to 35 millimeters anterior to the external auditory canal. This deep dissection reveals the nerve's ascent. Dashed lines track its path, coursing antero-superiorly, pinned directly to the undersurface of the retracted temporoparietal fascia. It continues along this hidden surface until entering the frontalis muscle, penetrating maximum 2 centimeters above the superior orbital rim. To safely expose the zygomatic arch, the dissection must remain in an exact narrow plane between the temporoparietal fascia and the superficial temporalis fascia's periosteal fusion. Devastating eyebrow paralysis is prevented entirely by maintaining the dissection within this highly specific fascial envelope. Once the soft tissue flap is safely reflected, the exposed facial skeleton grants direct entry into the deeper structures, including the medial orbit. The medial orbital wall is composed of the maxilla, the lacrimal bone, the ethmoid, and the sphenoid bones. The anterior third contains the lacrimal fossa, positioned precisely between the anterior and posterior lacrimal crests. The middle third is formed primarily by the extremely thin lamina papyracea of the ethmoid bone, reinforced only by the ethmoid air cells behind it. This view demonstrates strict metric navigation. From the anterior lacrimal crest, the anterior ethmoid foramen is 24 millimeters deep. Continuing this axis, the posterior ethmoid foramen sits 36 millimeters deep, and the optic canal lies 42 millimeters deep. The ultimate safety parameter lies at the end of the sequence. The physical distance between the posterior ethmoidal artery and the optic nerve is never less than 3 millimeters. Navigating the deep medial orbit requires strict adherence to these fixed metric landmarks to establish location and avoid catastrophic optic nerve injury. Executing the complete bicoronal approach requires synthesizing these regional rules into a continuous strategy. In the midline, the rule is mechanical efficiency. Utilize the subgaleal loose areolar tissue for rapid, bloodless cleavage from the cranium. Laterally, the rule is visual recognition. You must precisely identify the moment the dense galea transitions into the thinner temporoparietal fascia. In the lateral danger zone, the rule is protection. This anatomic U reinforces the exposed position of the temporal branch of cranial nerve 7, crossing just anterior to the articular eminence, protected only by the deep surface of that fascia. Executing the bicoronal approach involves a calculated, three-dimensional navigation of changing fascial planes. If you found this breakdown of surgical anatomy highly useful, hit subscribe, and let us know in the comments, which dissection plane do you strictly prefer when performing a zygomatic arch reduction?